7:34, and while we do have a thin attendance, we'll get started for the sake of time. And we will go a little bit slow for others to catch up if they join late. Otherwise, we'll continue our discussion with the current attendance. I'll begin with my formal introduction. Good evening all to the weekly huddle. My name is Anup Agrawal. I'm an interventional cardiologist at Care Hospital, Hyderabad. I'm joined by my colleague and co-host for the huddle, Dr. Praneeth Polamuri. The huddle is our audience level interaction where we discuss a variety of things, mostly related around healthcare. And we typically pick a topic and or a clinical case, and then we restrict our discussion around that topic. The basic premise is to bring our casual hallway discussions to a more organized platform like this one, and we share our ideas along with it. And while we do want to talk about science, we are mostly interested in bringing out the practice patterns and understand why you make a particular decision that you do in your daily activity. So with that, this is our 31st session where we are talking about stroke prevention in atrial fibrillation. And as a cardiologist, this is something very common that we see in our daily practice. I do want to remind that Huddle is not a speaker and audience model, rather an audience level interaction, which means if at any time you have any input to share, you can just unmute yourself and give your input. As a courtesy, we may request you to wait for others to finish their thoughts before you unmute yourself. So having said that, I'm going to get started with the clinical case. Typically, the format of the huddle is I start with the clinical case. I ask my colleague Praneeth to give his input, and then we open it for discussion for others. Because it was a cardio-neuro topic, I also was hoping that few of the neurologists would join us so that we can have a multi-specialty discussion. So while they do join, we are going to continue with our discussion. So here is my clinical case. And Praneeth, I'm going to ask you two questions around this case. Number one is, how common or uncommon you think cases like these come to our practice? And second, how would, in your best clinical judgment, how would you manage this patient? So the patient details are follows. This is a 74-year-old male. He has got a history of long-standing diabetes, probably going on for around 20 years. He's hypertensive, coronary artery disease on medical management, and for that he takes a single antiplatelet clopidogrel. He was diagnosed atrial fibrillation around 4 years ago, and he had been put on warfarin since then, which he takes very religiously. He occasionally complains of orthostatic hypotension, but he says that is manageable, and most of the time with his behavioral changes, he is able to combat his symptoms. Unfortunately, around 2 months ago, he was admitted to our hospital with a fall. So essentially what happened is at night, he woke up to go to the bathroom, and probably he woke up a little bit faster. He woke up, and immediately after he took 2-3 steps, he felt dizzy and fall down and hit his head to the side of his bed. He did not lose consciousness or anything. He just felt dizzy momentarily. On arrival to the hospital, we diagnosed him as subdural hematoma, neurologically stable. He required surgery because of the expanding hematoma, but he recovered from that quite well. He was in sinus during throughout the stay. I believe he stayed for around 4 days or so. His INR on arrival was 3.2, which was reversed, and his anticoagulations were held during the entire episode. He is now following upon with me after 2 months. So this admission was 2 months ago. He's ambulant now. He doesn't have any active cardiac issue, no chest pain, nothing else. He's feeling okay. He's off anticoagulants and antiplatelets for these 2 months now. He did get a 3-day Holter, which I advised him to get before he sees me. So he got a 72-hour Holter done, which showed few runs of asymptomatic atrial fibrillation. Rates were controlled, mostly around 100 to 110 when he would have atrial fibrillation. His sinus rates are in about 65 to 70. His rest of the clinical parameters are within normal limits. I'm not telling you all the other lab findings and stuff, but whatever I'm not telling you, you can assume it to be normal. If there is any particular question, you can ask me. He is taking statins, beta blockers, and ARB, among others. He's obviously on diabetic medication. Once a while, he still has got these orthostatic symptoms, but that is not his issue. He says, I'm fine. It's just that When I don't pay attention and when I get up a bit fast, then only I get the symptoms. His blood pressure at home ranges mostly 140s to 150s sitting down. And his blood pressure at the OPD was around 150, diastolic around 86, 88 or so. So this is the patient, Praneeth, who comes to me after 2 months, CAD on medical management, atrial fibrillation, paroxysmal with high CHAD score, recent intracranial bleed because of probably orthostatic hypotension, no arrhythmia whatsoever. His both clopidogrel and warfarin are held right now. And now we need to decide what are we going to do for stroke prevention on this patient, understanding he also has got other comorbidities. So 74-year-old male, I would get your opinion, Praneeth, what would you do in this patient?
Yeah, good evening, everyone. So, Anup, the first question that you asked me about how common are these group of patients or the patient with these kind of symptoms, I would say it's almost quite common. This is something which you very frequently see in your OPD practice. Uh, Almost all the risk factors and every time a probable diagnostic dilemma, whether it is a stroke versus syncope, transient ischemic attack versus arrhythmia related issue. Again, this patient, of course, had trauma, the fall leading to injury that is producing subdural hematoma rather than subdural hematoma producing his syncope. Sometimes finding this becomes difficult because even in the patients who are on anticoagulant, they sometimes have subdural hematoma presenting as a probable loss of consciousness or altered sensorium or whatnot. So this patient probably we expect it to be trauma related subdural hemorrhage. But yes, so at one end he has all those risk factors which put him at an higher risk of stroke and equally an indication to give anticoagulation. At the same time, he has a bleeding issue where you have to stop anticoagulation. Most of the risk factors they do have or share both from the bleeding aspect and also from the ischemic complications aspect. So I would still try to see here. I would say more in favor of orthostatic hypotension being the culprit producing all and producing the event. I really doubt whether he's had a transient ischemic attack. So I would be tending to favor giving him more of giving anticoagulation. I would be tilting more towards that and try to titrate his antihypertensive medication and try to counsel him taking care about his orthostatic hypertension. That would be my take on this.
And Praneeth, if you do want to start him on anticoagulation, what would you start? Remember, you have to answer both for antiplatelet as well as for anticoagulation. And would you tinker around with his blood pressure a little bit? What would you do? His resting blood pressure is around 150 by 88.
Yeah. So for stroke prevention, definitely he needs anticoagulation. Maybe I would be preferred to switch over to newer oral anticoagulants because the time in therapeutic range for warfarin or the vitamin K antagonist is variable. So sometimes you can still have higher INR or lower INR. So I would be preferably switching over to a NOAC with a less bleeding risk, preferably be an apixaban half dose 2.5 BD, just as some studies show it to be having a lesser bleeding risk. Maybe stop his single antiplatelet which he is receiving because his coronary artery disease seems to be stable, though he has risk factors. So I would take that risk of stopping an antiplatelet and continue a low dose apixaban 2.5 BD. Regarding hypertension, yes, again, in this age group, we want to aggressively control, but not at the expense of postural hypertension. And if postural hypertension is bothering me, then I would be happy to or be more liberal in stopping or reducing his antihypertensive medication or give him a short dose antihypertensives probably in the morning and skip his longer acting antihypertensives which may produce postural hypertension during the night time.
So in these kind of patients, what would be your drug of choice for antihypertensive to reduce postural hypotension? I told you he's on beta blocker and ARB.
Huh.
What is your drug of choice?
So I may switch over to shorter acting calcium channel blockers, something like shorter acting nifedipine or something like that, that retard formulations which usually act for 6 to 8 hours, uh, preferably giving him in the morning and skipping the night dose where he's more prone to hypertension, something like that.
Perfect. Thank you so much, Praneeth. And with this, we will invite suggestions of others. And I'm still trying to see if I have a neurologist in the group. So far, I don't. Dr. Chandramukhi, if I could get your impression, I will recite the clinical case summary to you, and then if I could get your impression. This is a 74-year-old guy, diabetes, hypertension, CAD on medical management. 2 months ago, had a fall, probably related to orthostasis. Hit his head, got subdural hematoma, got better, all good. That is 2 months. Now he's coming back to your OPD. He's not on clopidogrel, he's not on warfarin. At the time of fall, his INR was 3.2. Now, of course, it is normal because he's not taking those medication. The question here is 74-year-old guy with this kind of background. Do you think you would put him on stroke prophylaxis? That is number one. And number two, if you do put him on stroke prophylaxis, what would you choose? Now, just to give a background, his CHAT score, if we calculate, is going to come around 3. And that 3 would put him at an annual stroke risk of somewhere around 7 to 8%. So not insignificant, certainly a number that we need to think about, but certainly not a score of 5 or 6 where it's pretty high. So ma'am, patients like these, how do you play? Do you put them on drugs? If you do, what?
Hello, good evening, Dr. Anup and all. Did this patient have atrial fibrillation?
Yes, so this patient has atrial fibrillation. Sorry if I missed this. He was diagnosed 4 years ago, and he has got
Okay.
paroxysmal atrial fibrillation.
Yes, so with the history of atrial fibrillation and with a very like a TARVA score of 3, so I would certainly like to put this patient on oral anticoagulation. So as already Praneeth has mentioned, my choice will also be newer oral coagulants, especially apixaban or rivaroxaban 15 mg OD and apixaban 2.5 mg BD. And as orthostatic hypotension was like thought to be responsible for his syncope, as already has been mentioned, his antihypertensive drugs needs to be adjusted carefully. And definitely, I would like to add oral anticoagulation. And as Praneeth said, that his CAD, like it is stable. So he's having like any some bleed was there. So for temporarily, we can stop the antiplatelets and put him on oral anticoagulation. And later on, once the bleeding issue is sorted out, we can again switch over to clopidogrel 75 mg OD and either rivaroxaban or apixaban. Thank you.
Thank you so much, ma'am. One discussion point that I do want to bring is whenever we talk about oral anticoagulation using warfarin acetrom versus the newer anticoagulant, one thing that we have seen from the both randomized trials as well as observation is that efficacy-wise, these drugs are a little bit efficient. And a little bit efficient means, let's say, if warfarin reduces your stroke risk by 2/3, so I would say maybe, let's say 60, 65% or 70%, then adding NOAC reduces the stroke risk by 10% more. So we are talking about somewhere of the order of 70% to 80%. So certainly there are still 20, 30% patients who are left uncovered when these patients are given anticoagulation, either in the form of warfarin or in the form of VK or NOACs. Having said that, the situation where NOACs outshine VK is in the risk of spontaneous intracerebral hemorrhage or intracranial hemorrhage. So these are the patients who didn't have an injury. They, on a random day, they got intracerebral or intracranial bleed. So spontaneous intracranial bleed, if you look at the rates with NOACs, are almost half that of rates with VK. So whenever we talk about the safety profile of NOACs over VK, we are mostly talking about spontaneous bleeding, particularly inside the brain. Whether switching from VKA to NOAC will reduce the risk of trauma-related bleed or not, which particularly in this case that we're talking about, that part of science is not very clear. So I believe with both Dr. Praneeth and Dr. Chandramukhi, we have one consensus opinion that they would like to anticoagulate this patient. And the choice is NOAC over VKA because patient had a bleed on VKA. I don't necessarily know if that NOAC would add any benefit in the long run or not, because if this guy falls on NOAC, he's going to bleed again. But regardless, at a baseline, NOAC is better than VKA. So one could question that 4 years ago when he was put on warfarin, he should have been put on NOAC to begin with. So switching from VKA to NOAC, I just want to highlight that when you talk about bleeding related to injury, that bleeding risk is more or less going to be the same, whether a patient is taking NOAC or whether patient is taking VK. But as a general, I agree, in this patient, NOAC is going to be better. So that was my a little bit of data behind. I'm going to keep asking opinion. Is there anybody in the audience who would not anticoagulate this patient, knowing that he's a 74-year-old, some orthostatic symptoms? And as we know, this is one kind of pathology that you can never completely get rid of. These patients, they will have once a while this problem. That is not going anywhere. And atrial fibrillation is also not going anywhere. So anybody who would do things differently, they can unmute yourself or raise their hand. And while you gather your thought, I'm going to invite other people to give their thoughts. We have Dr. Srirang with us. Dr. Srirang, I think you joined late. I'm just going to give you a brief summary of this case. 74-year-old guy, diabetes, hypertension, atrial fibrillation, medical menace, CAD. 2 months ago, had a fall, got subdural hematoma. And at that time, all his anticoagulants were stopped. He was on clopidogrel and warfarin, that was stopped. Now he comes back after 2 months of follow-up. He's doing fine. He's getting paroxysmal atrial fibrillation. The question is, should we anticoagulate him, yes or no? And if you do want to anticoagulate him, what do you want to do? And is there any other stroke prophylaxis that you would like to do on this particular case? Dr. Srirang, if I could get your opinion on this. Dr. Srirang, you are unmuted, but I cannot hear you. Maybe your mic is off or something like that. I cannot even hear the noise in the background. Dr. Srirang, we cannot hear you. Okay, sir, we are going to get back to you. Let me invite suggestions from or comments from other people. I cannot hear you. Sorry, Dr. Srirang. I'm muting you. If you could just check your mic once, please. Okay. I have Dr. Gaurav here. Dr. Gaurav is one of our DNB residents. He's a final year resident with us, exam going. Dr. Gaurav, you probably have more recent data with you than, because we get in a habit of not reading the most up-to-date data. Dr. Gaurav, what is your impression? If this patient comes to you, would you anticoagulate this patient, yes or no? If you will anticoagulate, how will you anticoagulate? And if there is anything else you would do? You could please unmute yourself and share your thought. Dr. Gaurav.
Good evening, everyone. Sir, in looking at this current scenario, I would like to go with NOACs only, first of all, because there is less chances of bleeding risk compared to VKS. So, Apixaban is most preferable in low dose, sir. And second thing, later on, once patient gets stable, we could think of this antiplatelets and other management. And say a third things, we have to look for this orthostatic hypotension in this case. So orthostatic hypotension cause must be ruled out first, and that should be managed. And regarding anticoagulant, I would go with this apixaban only. No X the categories.
Thank you, Dr. Gaurav. We have Dr. Shankar here with us. Dr. Shankar is a general physician, and it will be very nice to hear his perspective on this. Dr. Shankar, if you could unmute yourself, I hope you have heard the clinical case that we are discussing. Question is same to you. Would you anticoagulate this person? And if you do want to anticoagulate, how would you do that? And if there is any other thing you would do for stroke prevention? By the way, I'll tell you my opinion. I don't want to anticoagulate this patient. So, and I'll justify my opinion later on, but I'm looking for some takers. I'm looking for anybody who can support my decision. Dr. Shankar, what would be your take on this case?
He is an old man with atrial fibrillation with the Chadwick score around 3. I definitely anticoagulate him. Preferably the Novax are the preferable choice, especially either rivaroxaban 15 milligrams per day. In taking into consideration of his age, diabetes and hypertension of long-standing duration, probably there may be compromised renal clearance also, creatinine clearance also. So I preferably give low dose rivaroxaban 15 milligrams per day, taking into consideration of his adherence or compliance, or apixaban 2.5 milligrams twice daily. But how to tackle this orthostatic hypotension in this case? Somebody suggested nifedipine, but the calcium channel blockers are more prone for hypotension. More orthostatic syncope also quite common with them. But how to tackle this? So we should take other non-pharmacological measures, and if possible, is there any role of midodrine? That I want to take opinion of the house. Thank you.
Thank you so much, sir, for your opinion. Really appreciate. We have got Dr. Amir with us. Dr. Amir, if you could share your thoughts about this particular case. I am looking for at least one vote in my favor of not anticoagulating this patient. Dr. Amir, what would you think of this case? And how would you approach? If you could unmute yourself and share your thought. Dr. Amir, you will have to unmute yourself. I'm not sure if you're able to hear me. Probably I'm not audible to him. Dr. Praveen is an assistant professor cardiology at Osmania. Oh, he was in Osmania. Sorry, now he joined somewhere. Praveen, you came late. I'm just going to give you a brief summary of the clinical case we are discussing. I would request your opinion. 74-year-old guy, diabetes, hypertension, CAD on medical management, atrial fibrillation for 4 years on warfarin. 2 months ago gets a fall, probably related to orthostatic hypotension at night, gets subdural hematoma, stays 4 or 5 days in the hospital, gets better, anticoagulant, platelets, antiplatelet are all stopped. He's fine now. After 2 months, he comes to my OPD. His Holter shows paroxysmal atrial fibrillation. I have to decide whether I need to put him back on anticoagulant or not, or what should I do for stroke prophylaxis for this patient. Warfarin versus acetrom versus Novax versus doing nothing versus doing something else, and what to do with this antiplatelet agent. So Praveen, if you could share your thoughts.
Good evening, everybody. So I'm Dr. Praveen. I'm working at Khammam actually. I'm not at Usma here. Hello?
I got confused you with a different Praveen. My apologies for that. I got you
Yes,
confused with
yes,
the
sir.
different.
Yes, sir.
Please go ahead. Please, Dr. Praveen, go ahead.
In your history, it's like the patient is a very elderly, frail patient and who had a recent surgery. I don't see, I will be very cautious in anticoagulating him. I may probably not anticoagulate him also. Regarding his orthostatic hypertension, that is definitely because of his underlying medication, which like to adjust them and try some non-pharmacological opinion. Midodrine, I don't think midodrine will be helpful for this patient in this setting. Regarding if his subdural hematoma, it's not progressing and small AF, I would be very cautious in anticoagulating in this patient because the chance of worsening his subdural hematoma and recurrence are very high when compared to the risk of stroke, provided his diameter and other things are within normal limits. If there is some LA diameter enlargement or any other risk factor for atrial fibrillation, then I would think of going with a non-form, NOACs, rather than warfarin or the.
Thank you so much, Dr. Praveen. I am muting you. We have got Dr. Rukmini with us. Dr. Rukmini just joined. She's a neurology consultant. Dr. Rukmini, I'll review the case with you and then we can get your opinion. And this is a 74-year-old guy with diabetes, hypertension, coronary artery disease on medical management with single antiplatelet, diagnosed with atrial fibrillation 4 years ago, for which he was put on warfarin and he was tolerating it very, very well. He has periodic episodes of orthostatic hypotension, which he is able to manage for most part well without any problem. 2 months ago, he woke up at night to go to the bathroom and he felt dizzy, fall down, hit his head, got subdural hematoma. That is when he was admitted to our hospital. INR was 3.2 at the time. He was his anticoagulation was reversed, antiplatelet was stopped. He underwent a mini craniotomy, decompressive craniotomy, got better, and he was discharged in about 4 or 5 days. Now he comes to me after 2 months of follow-up. In fact, our neurology colleagues sent him to me. He did get a Holter done, which shows he has got paroxysmal atrial fibrillation, rate controlled, no other problem. His baseline blood pressure sitting is around 140, 150, and he takes a beta blocker and ARB for that. So the question that is for us was how to put his anticoagulation and whether we should even consider stroke prophylaxis in these kind of patients in a 74-year-old guy, because no matter how much we control this orthostatic hypotension, there are going to be these episodes, particularly at night, when they wake up without a lot of thought process into it, and they get dizzy at that time. The question of whether midodrine is going to help to combat orthostatic hypotension. So 2 questions for you. One, as a neurologist, can you do something for orthostatic hypotension? And B, how worried you are for stroke prophylaxis in this patient? Is it something you would like the patient to be on, and how we can mitigate this bleeding risk in the future? Dr. Rukmini.
Thank you. Actually, I'm sorry I joined late, but this is a difficult scenario, but it's a very common scenario actually. It is, I mean, you have to choose between the devil and the deep blue sea basically. So yes, a person with 74-year-old with a paroxysmal AF, the chance of stroke is there. I mean, and you would, if it was not for the fact that he had orthostatic hypotension, and I mean, I think if there was no orthostatic hypotension and he had no faults, I think everybody would agree that he has to be on anticoagulants. I think that point is already, I think, established. And he has AF. So the question now comes that he has orthostatic hypotension, he has a fall, and he has a traumatic subdural hematoma. A subdural hematoma is a difficult, I mean, it's not such a, in an older individual who is more than 70, you have a subdural hematoma, and you evacuate it, and the risk of recurrent subdural hematoma will always be there. even with minor trauma, if he doesn't require to actually fall down and get injured to get a subdural hematoma. Even with a small trauma, once the space develops, there is a chance that he could bleed back into the same space again. So that risk is there. So it is a big risk, but I mean, so it is like and so the second thing is orthostatic hypotension. The question about how to control his orthostatic hypotension, I think in the last we had a discussion on modifying the antihypertensives, giving him salt and water, keeping his head end up, probably adding midodrine, again keeping in mind that it could cause a supine hypertension. I mean, and checking all the drugs that he's on, see whether we can actually mitigate the orthostatic hypotension. If he's not mitigating the orthostatic hypotension, probably asking him not to go to the bathroom. I mean, I think this is something which I keep telling my patients. If there's a risk of them falling down, I tell them not to go to the bathroom at all. They can use a can and have a bedside can to pass urine in the night. It is actually much more safer and much more easier for everybody else concerned with them. Now, with that in mind, if the AF frequency is very fast, if there is a clot somewhere, he's already had a TIA, I would think that I would put him back on the anticoagulant. Telling the patient attendant that it is like this, it's a high risk, I will probably you may have a bleed again. So that would be my contention. Because I've seen patients who developed a stroke after stopping the anticoagulant. That's a risk. So you have to take the risk. You have to take the risk between having a stroke and having a bleed. If you have a non-traumatic bleed, it's a contraindication to put back on anticoagulant. You cannot put the patient back on anticoagulant. So that's how it goes. It has to be individualized. I'll have to look at the patient, talk to them, see how they are going to manage him in the house, and then only take a call on it.
Thank you so much, ma'am. Praneeth, I have a question for you. This whole discussion about patient who have some coronary artery disease, putting NOACs having some so-called inherent antiplatelet effect, so you don't need to give antiplatelet to these patients, so you put them on NOAC. How much do you buy that? And patients, particularly who have got diabetes, hypertension, and established CAD, how comfortable you feel in stopping antiplatelet in these cases?
So, newer anticoagulants having antiplatelet effect, yes, I heard about it, but when the coronary artery disease is high, particularly when we did an intervention, I would be definitely depending on an antiplatelet, but versus someone who did not undergo any revascularization, and he's been quite stable for quite some time, maybe 1-2 years down the lane, I would be comfortable stopping antiplatelet. It's like balancing that ischemic risk that this patient have. But I would try to look them as an anticoagulants only without whatever antiplatelet effect that they are going to offer to me. I still would like to take on the antiplatelet if the patient is indicated. So maybe more data with that COMPASS trial also trying to say about those anticoagulants having an antiplatelet effect and all. But for me, I would try to see them as two different classes. If the patient is indicated to be having antiplatelet, I would still be edging more on giving him an antiplatelet.
Thank you so much, Praneeth. And I have reserved the best for the last. We have Somaraju sir with us. Dr. Somaraju, you have been there in the discussion since the very first minute. You heard everybody opine about this particular case. I would like to get your opinion. And again, the questions are the same. Would you anticoagulate this patient? And if you do, how would you do that? And other stroke prevention strategies. Dr. Somaraju.
Thanks. Thank you, Anup. Number one, first thing I would say, we have a concept called causes of causes. The original combination of warfarin plus clopidogrel in this patient was wrong. Whoever did that was wrong. And that should not have been done. The subdural hematoma couldn't have happened without that. There was no indication for antiplatelet plus warfarin in a 74-year-old person with no stent in and no indication for specific, that was wrong. That was the beginning. And then now in the present situation, if you ask me, Dr. Pranit said he would give calcium channel blocker. With atrial fibrillation and stroke of any kind and intracranial problem, ACE inhibitor, ARB are the drugs of choice. And whether this patient requires any antihypertensive is a different issue. But calcium channel blocker is not to be even thought of. And secondly, if you give an antihypertensive, give it in the morning time, not in the evening or afternoon. And I would like to rule out obstructive sleep apnea for him. And I also want to know whether he is taking any drugs for any benign prostatic hypertrophy, etc. And having said that, the first requirement in all these situations is do no harm. I agree with the neurologist who said the chances of rebleed are very high in such patients. And then if you are giving any anticoagulation of any kind in this patient, the tendency for a 75-year-old person, the vascular system is in a state of continuous tendency to bleed. And the body systems try to prevent the bleeding by clotting mechanisms. If you want to give any anticoagulant like newer anticoagulants, you are talking about that is harming the patient. And then I will, in this present situation, it's not an easy thing you are dealing with. And talk to the family, not to the patient, all this. And try to find out what they expect out of it, what are the issues, what are the problems related to any form of therapy we give them, and ultimately go by that. And I will not give him anticoagulants, oral anticoagulants of any kind. If at all I give him, I may give a single antiplatelet or even nothing for a while. And I would want to rule out an obstructive sleep apnea in him. And you didn't tell me the postural hypotension, you said, didn't tell me what is the standing blood pressure.
Thank you so much, sir. So to answer a few of your question, he is not taking BPH medications. When I checked it in my office, his standing blood pressure was not that different. His sitting blood pressure was 150. His standing blood pressure was 140. So at least.
So if the postural hypertension is not there, I would say don't take shelter on it. And the falls in elderly people occur even without postural hypertension. And try to rule out obstructive sleep apnea. Don't start him on any oral anticoagulant. And in case you want to give anything, give him a single antiplatelet. The drug of choice for control of his hypertension is ACE inhibitor or ARB. It is shown, neurologists will tell you that ACE inhibitor ARB in hypertension plus atrial fibrillation, there is evidence in the literature that they reduce the incidence of stroke. And if you give antihypertensive, give it in the morning or afternoon, not in the evening bedtime. Thank you, Anup.
Perfect. Thank you so much, sir. And so just continuing on that, I was looking for at least one vote to not anticoagulate this patient. I got one vote. Pranit, if I may dare to call you again and ask you, you heard Somaraju sir say not to anticoagulate this patient.
Yes, I want to hear from you about your role or your take on why do you don't want to anticoagulate this patient.
Oh, so, while I do subscribe to the do no harm kind of strategy, I personally think that not anticoagulating a patient with a stroke risk is also to a certain degree harming the patient. So sometimes not doing may also harm. We should look at the secondary causes of everything that we discussed, going from obstructive sleep apnea to the sleeping posture, to why the guy is falling, and also to look at his room structure, house structure, to see what we can do get rid of all the hurdles that happen. Sometimes carpet rug is there, sometimes there is a lot of barriers there, and also to install handrails wherever, whichever are the touch points, to make sure even if at night they do have a fall, at least they are able to break their fall. So all of those things, and vitamin D deficiency in elderly is certainly established factor for recurrent falls. So we certainly should replete their vitamin D level. So all those reversible factors we do talk about, but having said that, not anticoagulating patients with a stroke risk of about 7-8% annually, to me, that is also doing harm, particularly if the life expectancy is more than 5 years. If the life expectancy is short, then I wouldn't do anything. And in this particular case, where there was no any other organ damage, I would expect him to live more than 5 years. And there, I do want to do stroke prophylaxis. But I'm scared of anticoagulation. And I do agree with Samaraj sir that it is difficult. Rukmini madam said the same thing, that giving anticoagulation is scary. These guys, they may bleed just by doing nothing. And truly speaking, one of the reasons why I brought this discussion today is to think of...
Sorry to interrupt you. I said shared decision making. Sit with the family and make decisions.
Absolutely, absolutely, sir. I think that is very relevant. And truly speaking, what we are discussing right now, in my opinion, that is what we should be discussing in the OPD with the patient and the family in terms of what we are choosing and what not. But to complete my point, one of the reasons why I wanted to bring up this topic was to talk about non-pharmacologic measures of stroke prevention. And that could be atrial fibrillation control, that could be fall control, that could be all of this, but also to bring into notice role of catheter-based devices in these non-valvular atrial fibrillation, particularly those patients where we are stuck between rock and a hard place for anticoagulation. So one of the questions, now we are going to digress a little bit from the main clinical case, although the case scenario is going to be the same. The question is going to be role of catheter-based device therapy to reduce stroke risk, particularly devices like Watchman or devices like amulet devices, where you can give them stroke prevention. If you look at the data set with NOACs and with warfarin, we are talking about stroke prevention, stroke risk prevention of about 70 to 80%. With devices also, they are more or less the same. In fact, most of the devices, they would talk about stroke prevention of about, or risk reduction of about 70, 80%, at par with anticoagulant, certainly not better than anticoagulant. And the whole idea being that you can put a device and then you don't have to give an... Now these patients, they may still have stroke, but at the same rate as what they would get while getting anticoagulation, minus the risk of bleeding. So one of the things I actually wanted somebody to bring this up in terms of non-pharmacologic measures of stroke, of reducing stroke risk. And I do want to highlight a few things which I already said. Lifestyle measures, reducing AFib burden, making sure they are not vitamin D deficient, making sure they don't have sleep apnea and all this, which predisposes them to more fall, making sure they do limb strengthening exercises so that they can break their fall while they are doing it, changing their home scenario in such a way that their fall risk reduces, and even when they fall, they have something to catch upon so that they can break their fall. So while we do all of these things, we should talk about, and that is my opinion, and I would be opening this after a minute or so, about should we be thinking of doing catheter-based device closure of LA appendage using devices like Watchman or Amulet in these kind of cases, understanding that the procedural risk of these procedures currently is about somewhere of the order of 0.5 to 1% procedural complication. We are talking about pericardial tamponade requiring intervention and device embolization and so on and so forth. But 99% of the time, when you get a procedural success, And more than 80% of the time, you get clinical success at 1 year. Remember, clinical success at 1 year is not 100% because some of these devices, they do have residual leak. So if you look at stroke prevention of these devices, they are at par with anticoagulation, not better than anticoagulation. So Praneeth, this is my take on it. I'm not comfortable anticoagulating this patient, but I'm not comfortable leaving him alone as well because he does have stroke risk. And if I don't want to do any harm to this patient, then I don't want him to bleed, but at the same time, I don't want him to get a stroke. So what is your thoughts on it? And then I will ask anybody in the audience to give their thoughts about what my strategy is for this case. Praneeth.
Some of the things which I learned recently based on the probably not related to this case or seeing the other trial data and all. The age-related risk of bleeding is going to be more or less constant, but the ischemic risk is going to be probably varying depending on the amount of risk factors. So if we only look at isolated bleeding as such, so the bleeding risk, no matter whatever we call and say, probably is going to remain the same, but ischemic risk is something which is probably slightly higher. So my personal thing or what I could learn or infer from whatever I'm reading or learning is that we probably tend to favor or tilt more towards preventing these ischemic complications because bleeding, whether no matter how hard we try, still that bleeding risk is going to stay constant. So that's my take on this.
Thanks, Praneeth. I'm going to have Rukmini madam come in here one more time. Ma'am, what do you think about my proposal? Do you think this is something we should be thinking about this patient? I can understand the procedural aspect, you probably won't be able to comment, but these non-pharmacologic measures of stroke reduction, what is your thoughts on it?
I mean, I agree with all of whatever has been spoken actually, starting from Somaraju's point of view. So the question first arises is how much. So the thing is that you'll have to first measure out how much is the risk of stroke in this patient. Obviously, I mean, I think that must have been done. So you probably have looked at CHA2DS2-VASc score, Hasbled score, all that.
Yeah, so
I mean,
I would say,
so these are
it's of the order of 7 to 8% per year. That is what I would suggest for this patient.
okay. So there is, as you said, atrial appendage closure has been tried for patients with AF who have a high risk of developing a stroke, and I think that's a good option to go for. If you think that the patient, because you have to look at if you have a Hasbled score is deals with hypertension, poorly controlled. Already that patient already has a bleed. The INR is a little labile. So all that put together, if the Hasbled score is more than 3, then you cannot put the patient on oral anticoagulants. And actually, the trials came up like that for atrial appendage closure to prevent stroke in patients who cannot be put on oral anticoagulants. I think that's a good option to go for. Though I really don't know how many. I mean, I haven't seen it being done, so I have no experience with it. But the studies have shown a good result with that. So the thing is that yes, everything has to be individualized. You have to really look at the stroke risk, look at the bleed risk, and then take a call on how to go about it. The other question that I just wanted to know was that INR was 3.2. As a neurologist, we actually tend to keep our INRs a little on the lower side for patients with stroke. So we probably put it around 2 to 2.5, actually, instead of putting it at 2.5 to 3, because they tend to have a worse bleeding manifestation.
Certainly, ma'am,
appendage closure is a really good point.
So certainly this INR target, I think more and more we are getting comfortable with the INR around 2.5 range as compared to 3.5 range, because we realize, in fact, if you look at most of the data set for warfarin back in the day, patients are typically therapeutic only around 60-65% of the time. So the whole aggressive anticoagulation is dying off now. Now we are getting less and less aggressive on that anticoagulation front. So certainly from the cardiology side as well, not that aggressive, but you understand it's very difficult to have a very precise control on INR to keep it exactly at 2.2, 2.3. Let me bring in Chandramukhi madam one more time. Chandramukhi madam, what is your thought with the same clinical case that I asked you earlier? What is your thought of LA appendage closure? Is it something that we should think about in these cases?
Yes, I agree with you that we can LA appendage closure is a good option in this case because he has a high risk of both the stroke and bleed. So LA appendage will be a good option in this case. Thank you.
Thank you so much, ma'am. Anybody has any other suggestions? I'm going to ask Somaraju sir about his opinion for this particular therapy option that I wanted to discuss. Anybody has any other thoughts on this? Somaraju sir, if you could unmute yourself and share your thoughts about in this particular patient, do you think we are going to do any justice by even talking about LA appendage closure in him?
Actually, several years ago, we tried to do a trial on LA appendage closure. From that time to now, LA appendage closure is slightly better off now with complication rates acceptable. But it's not a common procedure in this country as yet. So you must discuss this openly with the family again. And again, I want to go back on saying that if you want to do anything like that, and even after that, say, LA appendage closure, the chances of embolic risk still remains a small percentage. It has to be shared with the family.
Thank you so much, sir. Dr. Praveen, you had anything to add?
Yeah, I completely agree with Somaraj sir because the number of procedures of LA appendage closure are very less in and the concept of risk is still the same. The morphology of LA and I would like to think of those issues also, the velocity effect. Is it an effect in the LA appendage? What is the velocity? Before considering choice of LA appendage and LA dimensions, everything. So it's not a, I would I don't think it's not a thing which I would go with my patient.
Thank you so much, Dr. Praveen. And since we did talk about device for maybe a minute or so, I'll just share with you. So there are two devices currently available in the market. There are actually three devices, but the third one really don't have good experience. So the first one is the Watchman, which has got the highest international experience. And early on, Watchman got a bad name because of very high complication, about 5-6% procedural complication. It was very high. And that was attributed to how the device was designed, because LA appendage is a very thin, it's a paper thin structure. All it requires is one catheter to go there and rupture it. So at that time, devices were not very friendly. It was a first generation device. The second generation Watchman that came around, that was the complication rate I was talking about, which in the first data set was 4.5%, and in the second data set was less than 1% or 0.5% or so. That certainly gave a boost to the International Society, and this led to approval of Watchman. But still, in India, problem with Watchman, number one is the cost. It's a little bit costly device. And secondly, the expertise, as everybody pointed out, that it's not a routinely done procedure. It is not a very difficult procedure, but certainly not a routinely done procedure, and there is a learning curve involved. On the other hand, in India, we do have the Abbott device called Amulet. Abbott also came with the first device called ACP, or Emplatzer cardiac plug, which was a first generation device, again, not very friendly. And although ACP did not have any trial that was done, Amulet is the second generation device which is available to us at a reasonable cost as compared to Watchman, and reasonable also in cardiology. We talk about a few lakhs, a couple of lakhs rather than thousands. The second generation device also does not have any randomized data. But it has got good registry data with it, and much more user-friendly device. But again, not many cases being done around in nationally, let alone in a hospital or a center.
No,
Yes, sir.
can I interrupt here?
Yes, sir, please.
These devices are easier to deploy for an average Indian cardiologist because they have so much experience in septal puncture and mitral balloon valvuloplasty. And this procedure is easier than mitral valvuloplasty. So if cost is not an issue, the availability is not an issue, the family agrees, and if there is a definitive indication, most of our Indian cardiologists will do well. Whoever is doing mitral valvuloplasty.
Perfect. Thank you so much, sir. So yeah, so cost and availability, I think there is any procedure, any device talk is incomplete unless we do talk about the cost. So emulate, if I have to recollect, the device cost is around 2.5 lakh rupees, and the overall procedure cost to the patient comes around 3.5 to 4, depending on how much your hospital charges. I agree with you, sir, that most of the Indian cardiologists who have been working for some time, they are very well versed working at LA space. People in United States and Europe, they are not very comfortable working in the LA space other than electrophysiologists. But in India, interventionalists, they are quite comfortable working within the LA space. The only thing I want to add, if any of the audience who do
Again,
want
sorry to interrupt you, Anu.
Yes, sir.
Electrophysiologists don't have experience, but they still do it.
Yes, absolutely. So the audience who may participate in LA appendage, the only thing I want to add, other than your own experience of working in LA space, is that you never enter LA appendage with a wire. Always try to enter with a pigtail. That was one thing we learned in the first Watchman trial, that a lot of the times we were entering LA appendage with a wire. And no matter how soft your wire is, we realized that was causing a lot of perforations. So the traditional teaching is you put the wire in the pulmonary vein, put a pigtail, and then now you put your pigtail in the appendage and exchange it with a wire and do all this. So the idea here is if you can reduce your procedural complications, then certainly emulate over the long run is going to be both cost effective as well as less riskier in selected subset of patients like the one that we are talking about right now. And as far as Watchman is concerned, it is that device costs around 7-8 lakh rupees. And certainly there the cost effectivity may or may not suit a lot of patients that we have. But device closure is something that we should think of in this particular case. And I mean, at the sound and at the cost of not sounding humble, I must say that we discussed this for around 35 minutes in this particular meet, where we had cardiologists and everybody opining. And there also, device closure did not come as one of our first thought process. And this is probably one of the reasons why our case experience is very low, because we are not really looking at those particular cases, and we are mostly erring on the side of not giving anticoagulation, which truly speaking, for me, is a disservice, because we do need to reduce their stroke risk somehow. And emulate currently is a very reasonable, cost-effective way. Watchman has already been practiced. I know in Hyderabad, there had been few cases done. And again, few cases. It's not like one center has done 10 cases. So it is a less frequently done procedure, partly because the patient selection is not that robust. So that was my thought about it. And whenever I talk about non-therapeutic or non-pharmacologic stroke prevention, it doesn't start and end at LF and disclosure. I listed a host of other measures that we should definitely discuss with the patient and the family before we embark upon any of this. Remember, you put an emulate device, the patient goes home, has a fall again. No matter how much you prevent, they will get bleed again. So you have to take a holistic approach and work accordingly. So that was my thought about it. Anybody else has anything to add? Praneeth, did that address some of the concern that we were having? And one of the things that I do want to highlight in cases like these is once you put a device, you can very well keep them on single antiplatelet for rest of their life, and that too a low dose antiplatelet, and they typically do fine. So Praneeth, your thoughts on this, and I would invite anybody else to.
Yeah, no. So the kind of summary that you gave about L appendage closure devices was good. So yes, as you rightly said, particularly when we put a device which is a bit expensive, the general tendency is that people expect the results to be amazing, or they don't expect any more stroke. But as I said, the risk of stroke is not going to be eliminated. AF doesn't go. The need for anticoagulation doesn't go. It's only that the risk reduction is slightly better compared to not doing anything. This, I believe, is the biggest hurdle or the challenge to drive the point for the patient and the attendants. Probably that is why equally it is not that adopted in our practice, but definitely for someone who can understand about what we are achieving by putting in the device in these patients, we definitely should consider. It doesn't come as a thought process, particularly in when in a day-to-day practice. Most of the times, this thought comes in academic discussions or during those seminars and all. But maybe if we keep talking about these things, even during our regular practice, that this thought comes in, and for those deserving, we can definitely give this option of L appendage closure.
Thank you, Praneeth. Anybody else has got any other thoughts on the topic that we are discussing? We are 8:35, so I would like to close. But before that, I invite any other suggestions from anyone? Okay, if not, then I will certainly do the closing remarks. Somaraju sir, I want your opinion one more time. I remember asking you, getting your feedback on this session 1.5 months ago when we had you for the first time. Now I believe you have been with us for about 6 weeks now. Give us some feedback about how we can make it better, or how should we go forward with this?
I would say it's an extremely useful session, and don't be taken away by the number of people attend and don't attend. If good things are done, it has to be done, even when very few people attend or nobody attends. And I used to have an experience. I used to say, even if you have one student, you have to still take the class. And when I say even half student attends, you have to take the class. Half student means there is one student who comes but he is sleeping. So continue, and you are doing well. And I am learning a lot of things, and it's good for all of us. Good for medicine.
Thank you so much, sir. Praneeth, you already summarized it. If you could just give your closing comments for this session.
Yeah, so I like today's session. Typical OPD case scenario, maybe a problem both for a cardiologist and a neurologist about starting an anticoagulation after a bleeding event. Few learning points about subdural hemorrhage leaves at the residual risk of bleeding again because of the empty space created. Do no harm principle being highlighted by Dr. Somraju and others. So, and taking into consideration or talking to patient and the family, knowing their needs and trying to explain non-pharmacological measures about modifying their space, workspace, using a can not to get up in the night time for urination, and correcting the deficiencies of vitamins highlighted again to be considered before and all. And yes, if need arises to do anticoagulant, start with a lower dose to give them the option of L appendage device closure as well. So this is my take on this. Thank you for those suggestions. It was really a good session.
Praneeth, for these closing remarks, and with this, I will close the session. I thank Dr. Rukmini to join us for this for this session. I also thank all the attendees for today. We would love your feedback. So if you have any constructive criticism, please share it with us. We host this session every Wednesday at 7:30, and the link that you use to join, you can use the same link for future sessions as well. These sessions are recorded, and the recordings are there on podcast on YouTube. I run a bit behind in uploading them, so pardon me for that, but eventually they will show up. So on podcast or YouTube, you can simply just search the weekly huddle and you will get the past recordings as well. If you do want any of the recording email to you, just shoot me an email and I'll be able to send you that. Thank you again for joining and participating in this excellent discussion. Good night, and I hope to see you again next Wednesday. Thank you.